It's now my pleasure to welcome our second international speaker for the morning, and that's Professor Matthew Costa. Professor Costa is a Professor of Orthopaedic and Trauma Surgery at the University of Oxford, an Honorary Consultant Trauma Surgeon at the John Radcliffe Hospital. Matt is past President of the UK Orthopaedic Trauma Society and past President of the Global Fragility Fracture Network. To speak to us about hip fracture care in the Asia-Pacific region, please welcome Professor Costa.
Great. Well, thank you very much, Catherine, and thank you very much to HipFest for inviting me over. It's my first time in Victoria, and I have an amazing time so far. I've had some of the best wine I've ever had. So long may it continue. So as Catherine said, I'm an orthopaedic surgeon, but interested in fragility fracture care more globally, which I guess is my journey over the last 20 years or so, from just fixing bones to actually being much more involved in care more globally and increasingly sort of internationally. So no personal conflicts related to this talk, but I've been part of FFN for quite a few years now, is my major disclosure. So I was really fascinated by Stephen's story about Gordon earlier, and I think this is where we should start with all hip fracture meetings, really, about patients. We'll do something slightly different now. I'm going to take you through some experiences from patients in lower middle-income countries, some from South Asia and some from elsewhere around the world as well. So I'll just do this under a few headings. And I guess if you want to take a message from this part of the talk, is it's all about context, what you do in terms of data and quality standards, and we talk about that later on, really depends on what the patient's journey is that you're hoping to improve. So just a flavour of what patients are experiencing in the rest of the world. And I have no doubt at all that there's more we can do in my home in the UK and you can do in Australia and New Zealand. But the potential for improvement elsewhere in the world, as you can see, is absolutely massive. So this is really all about data. How can we use data? And you've heard very clearly this morning that data is incredibly powerful for changing clinical practice. In the UK, we actually managed to halve our mortality at 30 days following hip fracture, following the introduction of our hip fracture registry and the setting of quality standards. Admittedly, that was from a fairly high base, so always easier to improve from a terrible situation, and we were awful before the hip fracture registry. But we have now got below 6% for the first time in the UK at 30-day mortality, which, considering where we started, is a huge improvement. So how has this happened? And as you've heard, it's really about feedback. So the UK and colleagues of mine who know much more about this, pioneered this work, really would have, I think, the first to take a national collection of data system and make it readily available for everyone at any time. So you can go onto the hip fracture registry database in the UK and you can look immediately at your hospital data. And not only that, anyone can look at your data compared to the rest of the country. So you see immediately how your hospital is performing. My hospital at the moment is particularly terrible, huge embarrassment compared to the rest of the sort of country, and all our patients can see this as well, and they want answers. They want to know why we're performing so badly in there, and I know you're doing the same thing as Jackie described in Australia and New Zealand as well. So what sort of thing can you do with data? This was something that slightly surprised me. When I first started as a consultant trauma surgeon quite a few years ago now, I had anaesthetic colleagues telling me not infrequently that the patients we had in the hospital were too sick to operate on. You can't operate on this patient, they'll die. They need an echo, they need more blood tests, they need delaying for at least a week. Well, we looked at the data for this, and colleagues from the anaesthetic world compiled this. And this is just mortality, looking at the ASA grade, so how sick the patients are beforehand. And the take-home message is really that even if you have an ASA of 5, i.e. you are expected to die very shortly, your risk of dying on the day of surgery is less than 5%. Less than 5%, even if you're expected to die. So anaesthetics, an incredibly safe place to be, generally. It's not that you can't die later, and many of these patients do, but actually, under anaesthetic on day 1, you're incredibly unlikely to die. And this has radically changed practice in the UK. So now I have anaesthetic colleagues saying, you've suggested treating this patient non-operatively. Why aren't we operating? A complete reversal of the situation. I said, well, actually, they've been working on it for 3 weeks. It's a stable fracture pattern. You don't need surgery. Oh, you sure? I think we should still operate on this patient. So a massive change just based purely on data to show that it is actually safe to operate on these patients. So what about money? And this is obviously a contentious subject, and money, of course, is in short supply. Some of you may have noted we're on our 4th Chancellor of the Exchequer, the person in charge of money in the UK, in the last 4 months. So financial stability is a bit of an issue for us at the moment, and money is certainly going to be short over the next few years. So this is some work, I won't talk about this in detail, from David Metcalf from our group. And we did a natural experiment here looking at the comparison between the 30-day mortality in patients treated in England compared to in Scotland. So one healthcare system, our national healthcare system, very similar patient demographics across the 2 countries. But in 2010, in England, we started paying hospitals more money if they achieved quality standards for the care of their patients, and Scotland didn't. And what we were able to demonstrate using these data, admittedly after 10 years of data collection, was that the 2 curves in terms of mortality diverged. By paying hospitals for improving quality care, we actually got better outcomes and lower mortality for patients. So money does make a difference. So quality standards linked to financial incentives. But what do you pay for? How do you set the quality standards? And you've heard a lot about this already from Jackie, so I won't labour this point. These are, from a few years back, the 7 quality standards we set in the UK. And the really great move from my predecessors in the NHFD, National Hip Fracture Database, was that you didn't get more money for hitting one of these targets. You didn't get more money for hitting 2 quality standards. You only got the money if you hit all 7 standards. So it's all or nothing. You either treat people really well or you don't get the money at all. And that was really important. So work that will be discussed later, I think Xavier might talk about this during the rest of the meeting, we were able to demonstrate that by having these quality standards and using financial incentives, not only we could reduce mortality, but we could also improve quality of life for patients. But what about in other countries, going back to our colleagues working in low-middle income settings? And again, this is all about context. So here I'd like to acknowledge my friend and colleague Iwin Tabu from the Philippines, who's chaired the Regionalisation Committee for Asia Pacific through the Fragility Fracture Network, and himself and many colleagues across the region did all the work presented here. This is part of a much larger body of work looking at really mapping patient experience, service provision, and care pathways in Southeast Asia, which I won't go through today. What I'd like to talk about is a little work on actually mapping fracture care pathways in these countries with relation to what they mean for quality standard setting in those areas. So just as an example, let's take this quality standard from the UK of surgery within 36 hours. So here's some data collected at a facility level, looking at how quickly patients are treated in different countries and different institutions at the various different hospitals. So you can see that in countries like Thailand, the average day or the median time to surgery is 1 to 2 days. More patients actually having it on 3 to 4 days. But in countries like the Philippines and Sri Lanka, the median time to actually having surgery is 5 days or greater. So you could say, well, possibly a target of 36 hours might be a reasonable place to start for a quality standard in Vietnam and Thailand, but wouldn't be probably appropriate in Sri Lanka or the Philippines, or at least it would be a stretch. Maybe you put 48 hours. But that's looking at one element of the care pathway. You need to map the whole pathway in order to understand what the patients are really experiencing. So here's the data that describes how long it takes to get from injury to the hospital in the first place. So the previous graph was how long you waited from admission to have surgery. This is how long it took people to actually get to the hospital in the first place. So in Thailand and Vietnam, most patients present within a few hours via their ambulance systems, and certainly within 1 day. But the median time To get to hospital in the Philippines is 1 to 2 days, and many patients in some parts of this area are waiting 3 or 4 days just to get to hospital in the first place. In other parts of the world, in sub-Saharan Africa, they're often waiting much longer than that to actually get to the hospital in the first place. So in that context of waiting 5 days to get to hospital, it's kind of irrelevant whether you have surgery within 36 hours or not. Maybe the standard should be more about transport back into the hospital in the first place. So what about other quality standards from the UK? Here's assessment by a geriatrician. This is something we're very proud of. I think the biggest factor, I'd safely say, in the transformation of care in the UK has been involvement of my colleagues who with some genuine medical expertise, unlike my own. These are data looking at who actually sees patients when they're admitted to wards in low-middle income countries in South Asia. So pretty much everyone's seen by an orthopaedic surgeon. Orthopaedic surgeons' only real involvement, only really important involvement in this care, and I put this in the context of liking operating quite a lot, is actually to be the people that see the patients at the front door. Most places have nursing, and increasingly specialist nursing, of course, and physiotherapy access. But very few countries actually have geriatricians. In some parts of the world, geriatrics as a subspecialty of medicine does not exist at all. So setting a standard whereby you ask a geriatrician to see patients within 72 hours, where there are no geriatricians, of course, makes no sense. So who could see these patients? Well, actually, in countries like the Philippines and Thailand, rehabilitation medicine is a major part of their current medical practice. And actually, looking at the skill set of rehabilitation doctors in those countries, they do map fairly closely to what we might consider a skill set from an orthogeriatrician. They're certainly capable of doing a comprehensive geriatric assessment. So maybe the standards in those countries should involve a different group of medical specialists, but fulfilling the same sort of role. So there's many more examples I can give about how it's very important to understand the care pathways in the country before creating quality standards for that sort of country. The common data set works that Chris has described so eloquently, I think is a big step forward here. If we're all speaking the same language, then finally we can start to actually use our data from different countries to help other countries improve their quality of care. So I just promote once more, as though you needed it, the minimum common data set version 2, which I think will be actually transformative for many countries. And it was built specifically, as Chris said, to involve all countries around the world in all healthcare settings, not just in developed healthcare economies. So that's enough, I think, from me. I'd like to finish with data is a very powerful tool, and we think we've shown now in Australia, New Zealand, and other parts of the world that if you can set quality standards, you can improve quality of care for patients. You can improve their outcomes in terms of quality of life as well as mortality. But quality standards do need to reflect the systems in which they're set. Transferring a set of quality standards from the UK to the Philippines makes no sense at all for their care pathways and probably won't work. You do need to have bespoke data sets for different countries, but working as a network through the Global Fragility Factor Network, I think we can achieve this. Thank you very much.